Hi everyone, I'm Bongiwe Ndlovu from FAQ, the Better Health Group, and we're here as always on Wednesdays with What the Fuck, where we discuss real topics, real issues, and share what is currently happening that actually matters to young people. So we're here with real issues and real people, and we're saying no filter because it is What the Fuck Wednesdays. My guest today, I am so happy to have her here as we are going to be discussing quite a lot when it comes to health economy and also where we see the trajectory of our health systems. Our guest is none other than Professor Gesine Meyer-Rath. I said it right?
Perfect.
Welcome to the show. It's always lovely to speak to you when we do. I think one of the things I'd said to you earlier that I'm so excited to have the conversation with you because you are working more on the modeling and the numbers and the economy, and we are dealing more with the faces of the numbers. So I'm looking forward to today's conversation. But before we dive in, can I give you a moment just to explain who you are and what you do?
Thanks so much, Bongi, for having me. This is exciting for me as well. It's a very interesting format, and congrats on establishing it.
Thank you.
First off, I'm a health economist. I'm a trained doctor. I did infectious disease medicine for a couple of years, and then started looking at the cost and the other economic factors behind what interventions we can afford, what we can't, and who gets to say. And so very much from the beginning, my focus was on HIV treatment. I started 20 years ago. I know this ages me somewhat, but it's true. Or even longer, coming to think of it, in 2001 at WHO as an intern, and then kind of picked up the skills, did a PhD, etc. So now I'm using health economics as a bit of an advocacy tool to establish what the impact is of either providing or withholding an intervention, what the cost would be of both, and then comparing the one with the other, and that's basically where your cost effectiveness analysis comes in.
Yeah.
And we've worked mostly on HIV. We also have done quite a lot of work during the COVID pandemic over the last years. TB, we're working a lot now also on non-communicable diseases.
Yeah, I think this is a very impactful conversation because I remember I grew up during the days of Thabo Mbeki. So I remember firsthand seeing people pass away when decisions were taking too long to be made, and all of those deaths were preventable during the Truth and Action campaign and them taking to the park. Those were the days I grew up in, and to see how important health systems are in decisions, and as you're saying, modeling and putting it up to governments to make decisions, I think is at the core of what we do. And so I also just wanted to find out, because I know that you've originally from Germany, yes. So how did you end up in South Africa, and why South Africa?
This is, I think this is actually something really interesting that I'm discovering now over and over, that even those of us who still feel we're quite young, if at heart, discover that this is a huge déjà vu, right? So it's exactly that. All of this, the defunding of HIV programs that are on the horizon, even me going back to my old arguments about saying HIV treatment is worth it. It's actually, it's a business decision that makes sense. Really takes us back 20 years ago. There was this letter from the Anglican church to the mining houses a couple weeks ago that is a replay of what happened in 2002, etc. And you're absolutely right, during the Thabo Mbeki government, etc. So that was exactly when I came here, because I wanted to do a PhD on basically using economic arguments to make the case for HIV treatment in a low or middle income country, so basically poorer countries. There were a number of countries that my supervisor and others had contacts in, and one of them was South Africa. I almost ended up in Malawi. Then for some reason, South Africa came through first, and I've never looked back. But it has been 20 years of using South African data to show the world very much what the impact could be of ignoring AIDS.
And I like how you have said that there's an economic impact for slow decision makings, or not even taking interventions or taking advice. How do you compare? Because I know that one of the unique things that we always say, that health is wealth, and we talk about it at a very fluffy angle. But exactly what is the cost of governments ignoring the health and well-being of society, or even young people? Because I think from us, that's always our lens, where we see the toll that slow decision-making processes affect young people, you know? So what would you say is the actual cost of ignoring advice or guidance, or even having to make economic arguments to governments?
So I think there's different ways of answering this question, of course, and different levels at which to measure how it would play out, right? Or how not treating HIV would have played out, or how now into the future ignoring the threat that comes from the defunding of the current South African HIV program through the withdrawal of PEPFAR monies, the threat that poses, right? So, and I think it's really important for us to both talk about the numbers, but also about how it will feel. Also, especially for us who have been there, like you say, right? So when I arrived here, it was exactly that situation where everyone was spending there every Saturday at a funeral. And that feels a little bit like COVID when it was at its worst, only that lots of people didn't attend funerals because, you know, it was really very limited. But just this kind of, I think, all-pervasive dread almost, right, that one felt when the second wave rolled in and the third wave rolled in. And I don't think that any of us get to say we didn't feel it. You know? We weren't afraid. We didn't feel like an actual pandemic had us in its iron grip. And so I think AIDS was different because it was over much longer periods of time. There were aspects of shame attached to it, which we didn't see in COVID at all, right? No one blamed anyone for having gotten it, to be quite frank. There are huge impacts on trust between, you know, in a family, but especially, of course, in a relationship, etc., which I think we are still negotiating, and I'm absolutely certain young people are still negotiating. But when you have a higher population viral load, if there's a lot more transmission happening and you see the immediate impact of it because you are attending funerals, you see your own friends getting sicker, you drop almost as a generation of young people 20 years ago, right? There were these students being interviewed in Botswana who said, we are all going to die, because there was a 40% prevalence, and that was mostly in young people. And basically this hopelessness that translates into, I think a lot of us have forgotten. Many of us weren't around at that time. And AIDS has really, we don't even talk about AIDS anymore. We talk about HIV, which is exactly right. But it almost has become one of the things you don't worry about too much. All of this could reverse quite quickly in the next couple of years.
And I think if it wasn't for the ban, we wouldn't be none the wiser, because we see it also on our side. I mean, when we grew up, there was almost like a fear of, oh my God, I might get this thing. Now, children are just like, it's vibes. Like, if it's fine. I'm more afraid of getting pregnant than getting HIV. We get that a lot. So then what would you say that the biggest challenges are when you talk about challenges in South Africa in terms of making data-driven health policies? Do you think that there's a gap between what's currently happening in the policies versus what you're seeing in community level?
I think we are actually at the forefront, certainly given you know, our income level and, you know, poverty level and so on, when it comes to actually having fantastic data systems, especially around HIV. And it's one of those things that, because we had 20 years of kind of optimizing the HIV program in a way, we also were able to improve data systems, improve primary healthcare, improve the way people get trained at the, you know, healthcare workers get trained, improve community healthcare provision, and all of that, which is now benefiting people across the board, not just because of HIV, but really for all kinds of other diseases as well. So that's fantastic. And we noticed this during COVID, right? We were able to pivot, for example, testing. So from community level HIV testing to community level COVID testing. We had the lab capacity that the rest of the continent, you know, was envious of, and etc. We were able to actually count the deaths. Most other poor countries can't even do that, etc. So we have what we sometimes as modelers call a very good data to model, to budget, to decision pipeline. So basically where we, at least in the HIV space, can produce numbers very quickly for example, for a new intervention like injectable PrEP, lenacapavir. As soon as we knew what the effectiveness was, 100%. No one acquired HIV in the trial, went on lenacapavir. So we take that data point, we put it into our model, we know what things cost, or we put in assumptions about the cost, and then we can tell government very quickly, in this case, what the price level needs to be, what lenacapavir needs to cost for it to be as cost effective as oral PrEP, for example. So all of this is kind of set up. We've kind of taken a good 15 years to optimize it. It can be run really, really quickly. Then what happens is out of our hands, right? So this is where we as researchers provide the data. We don't make the decisions, and that's exactly how it should be. And then, of course, even if there is a policy decision based on that data, someone has to implement it. And of course, that's the really hard part. And someone has to tell everybody out there that, let's say, lenacapavir is available, not just yet, but hopefully in a couple of months' time, and people have to come and actually demand those services. And all of that, of course, is outside of what we can influence. Even though I do think that the more we talk about our numbers and the more we make it make sense and actually grab people, the more we can also help with demand creation. So those things can actually yield the impacts that we have modeled.
Yeah. Yeah, because I think when you look at that pipeline, you then see where the block is and what is currently causing it to be slower than what it would be. What would be your ideal recommendations in terms of implementation? And I think this is also a question that is coming from us being the demand creators, the people who are dealing with all the stigma to ensure that they go and get the services. So what would be your ideal sort of advice in terms of the implementation side of things, to say how can we ramp up there? Or is the block at the decision-making phase of the pipeline?
So I think when it comes to the current crisis, right, I think it's a very easy label to reach for. I think the biggest issue is, of course, from the outside. South Africa finds itself in a situation where right now we're in the doghouse for several reasons. Most of them are entirely defensible, some of which we are proud of. So I think that's as it may be, we can't help it. PEPFAR has been defunded, even if services are being or funded again or for some period, etc. I think for South Africa, we will need to plan for a future where that funding is not going to come back, and certainly not to this level. Now, we did an analysis a couple of weeks ago where we showed that if the South African government doesn't step in and fund and take over those services that were previously supported by PEPFAR, in particular support for key population programming, etc., including young people. So if the government doesn't step in, we will be facing between 56,000 and 65,000 additional AIDS deaths in the next 3 years. Now that is that's crisis level. It's not quite as bad as COVID, but it will be, people will feel it again, right? It will be funerals on a regular again, and it will be young people as well. And a lot of those deaths will in fact be in very small children, because that is where the mortality hits, right? People, babies born with HIV, that is one of the biggest risk then for mortality. We also kind of said what the budget needs to be to kind of fill this gap. It's quite an amount. When it comes to where's the gap now, so we have the data, they have been communicated. Of course, we don't really have the money lying around at this minute, right? True. So we are coming off the COVID pandemic, the fiscal space, as we call it, so how much money the country has available has reduced even between the 3 last budget drafts. We've seen it. It's a real thing. We have unemployment to fix, we have roads to fix, we have water, electricity, and other utility crises, etc. Right now, to go back to Treasury and say there's also AIDS on the horizon is a really, really hard case to make. But one that, as I said, we're kind of bringing up the old arguments in parts to show also what the macroeconomic impact will be of letting AIDS run rampant. rampant again.
And I think just to give kudos to our government, I know that South African government is actually is it the only country in Africa that currently has like a high percentage that's just funded through tax funding. So that on its own, you see that the capacity is there. And I think with us, it's how do we then start prioritizing it again? Because I think with us and our social media platforms, one of the reasons that we highlight and talk about sexual and reproductive health is because we know that there are still infections that are happening that are all preventable in this day and age. There are still unplanned pregnancies, so we can't really let the conversation go until that is resolved or even dropped to a minimal. And I think rightfully, as you're saying, that the trajectory, if you look at what the numbers are looking just from this drop alone, what would happen in 2 to 3 years? And those numbers are really scary. You know, when you think about how far we've come with the likes of Gossie Johnson's and where we are right now, it's like we're almost making a U-turn back to where we come from. Yeah.
And that is exactly our, I don't know if I can show the figure, it's actually quite harrowing. So not only are you and I kind of haunted by the idea that we're going back 20 years, but also so will the epidemic, right? So I don't know if someone can zoom in, but essentially we've come from much higher, right? So in 2006, so this is, these are the deaths, this is in the cases or incidents, but basically we've started from here. We were very close to actually ending AIDS, where we can get to a stage where we still have, you know, a number of AIDS deaths every year, but we really are more or less at saturation. And what we said will happen during, as a result of the defunding is another increase in deaths and in cases that would send us back 10 years. And that will again reduce life expectancy, right? And hopes for the future for young people. So if we get into this situation, we will feel it. Everyone will feel it. No one will be, you know, not in a position to say, I didn't know AIDS was a problem. As right now, you could still say, right? Could get away with it almost.
So how much then, because I think one of the things that we always champion is highlighting the importance of resources, as limited as they are, also being allocated to preventative care versus the sick care. Because I think with us, especially since we're dealing with young people aged between 13 and 25, we try and instill that health-seeking behaviour as early as possible, removing stigma as early as possible, you know, teaching them body autonomy, what are your rights in terms of accessing service and care. But then most of the time when we talk on platforms such as this, it's like we don't have money for preventative care. Okay, the question is, what currently do you think is the balance? So what is the percentage of resources that are being allocated to preventative care? And do you think that in the future, it's something that should be more focused on when you look at the numbers?
It's a very good point. It's a very good point. I think generally the majority of HIV expenditure goes to treatment, but that's also because per person or even per, you know, per person it's a lot more expensive. So a lot of that is actually warranted. We still need to get to the 95 targets. We're lagging behind in the middle, which is one of the most important ones, right? Which is really where we start seeing then transmission going down because enough people are on treatment. We know that people who are on treatment have, you know, I think it's now 92% of them have viral suppression, and that's what then reduces transmission. But we only have, I think it's 76% of people living with HIV on ART. And so that's the saddest thing. We keep adding people, but we keep losing people at the same time because the healthcare system clearly doesn't cater to people's needs, or not, you know, sufficiently, or not to, for all types of people, and that includes young people living with HIV. But beyond that, so I'm very happy to defend the amount of money that we spend from tax money, you're absolutely right, on HIV treatment, but we also can't end AIDS on the basis of treatment alone. True. And that is very clear to us. And then of course, when something as sexy as injectable PrEP, which, you know, you have to inject twice a year and you're done with it, you don't have to think about HIV again for 6 straight months. When that comes around, of course, we want, even in this limited fiscal space situation, we want government to walk into it bravely and basically make as much lender capital available as possible to especially also young people and people at risk, other people at risk.
Is the condom a past rhetoric? Like, are we, are we, is it even up for discussion? Because I think that's where we originally met, where we were like, we want a condom distribution. It's still the most cost-effective way to prevent. Is that conversation just out the door, or?
I think probably most of your viewers know more about just how relevant a condom is. To be quite frank, I grew up in a situation where we still had people, just like FAQ, coming to our classrooms and telling us about AIDS. I heard about AIDS, I still can't believe it, at the age of 10 in my primary school classroom as part of sex ed, which we had at that age. And it was basically, it had just been described for the first time, right? So it was kind of another 10-year-old boy talking to the rest of the class about AIDS. So this is how it can be done. And so for us, one of the coolest things you could give to a 12-year-old for their birthday was a condom voucher.
What?
And there were these cool condom shops all over Berlin where I'm from and so on. So I almost want to go back to that, and I can appreciate that not everyone feels like that, but I do think cool condoms would solve this problem. And yeah,
I think the feedback that we're getting in terms of condom usage from our digital community is the role that it plays in a relationship. So a condom represents mistrust, I'm dirty, I'm this, I'm that. So for us, we're like, okay, do we need to rebrand, like how you're saying, and position it differently? Because right now, how it's currently being positioned is something that is actually coming in between this partnership versus helping us on our sexual plan together. So I do think that the rhetoric does need to change. But when we look at the economics of it, I mean, the cost of a condom, and I do understand just the freedom of having 2 injections a year and then you're done. Definitely, I mean, there's no comparison there. But when we're talking about an economy and we're talking about what the state is, and also us as people who are the majority are unemployed, what then is possible? And I think just removing a condom completely then is just negligence on our end, because it's still a very effective tool. But ours then as the educators or the health literacy people is, how do you rebrand it? How do we make it a thing that is not? It's the same with STI testing kits. I know you also had an opportunity to work with the HIV home testing kits that you had challenges with there. How did you find that, I'd say, research project? How did you guys find, what were the challenges that you found with the home testing kits?
The self-test, the HIV self-testing, yeah, exactly. So perhaps on both fronts, I think exactly, condoms are the only cost-saving intervention against HIV. Every single time we compare all interventions, treatment, PrEP, or PrEP, injectable PrEP, against each other, and the top thing is always condoms. And that would still be true if they would cost 7 times more than they currently cost. And that's really important, right? So we could, as a country, afford sexy condoms. We could afford condoms that are, warm to the touch. We could afford ribbed condoms. And I think if you kind of pull out a ribbed condom, you're not just talking about dirt, you're also talking about
enjoyment, pleasure.
Exactly, not for yourself, but for the other person. So it's, I think that, there's a lot of conversations to be had about condoms that are probably a little bit more appropriate. You still have to have a conversation, which sucks in the middle of, doing something completely different. So it's, I personally don't think we're done with the condom. It's also, the big condom market makers just brought out something called skin to skin. So they can read the South African market better than our government. So if those condoms, kind of thin, warm, whatever, ribbed, were on the market, I'm for free, would kind of be given out, especially to young people, I am fairly certain we would see a different uptake very quickly. So that's the one thing. Self-testing, same thing. What we've learned about self-testing is that it's the most cost-effective if you give it to people at the highest risk, but also those are the folks who actually want to use it, right? Because so having a conversation where you say, okay, let's have, whatever this hookup, but let's quickly test. You test, I test, we look at the results, we take, we have a conversation, we take decisions based on that, is a fantastic way to kind of start, I don't know, a weekend of fun. So it's, I remember a couple of years ago finding in a private pharmacy a weekend package consisting of 2 self-tests and a whole bunch of condoms. And, why can't we give that out in the public sector, especially to young people? So, you take stigma and you take judgment away from it and you say, you want to have fun, here's your pack.
Yeah, true.
And if that's then not Max branded condoms, but, so properly branded, high quality condoms,
yeah, that is true.
Much for the better.
So what do you think that the future then looks like when you talk about HIV prevention? I don't know if I can add STIs in there as well, but because I know we've been talking about injectable PrEPs. I know that they currently also are doing studies that are successful. What does the future hold for us as a country?
We're at a fork in the road.
I can imagine.
Yeah. Yet again, it's in our hands, right? No one's. I think that's a problem with kind of being at the receiving end of charity. It's nice while it's there, but you don't get to claim it when it's being taken away. And so, for us as South Africans, we're so used as health being a human right, and we know it is. And there've been law cases and court cases one after the other to show that this is a real thing in South Africa and the government will be held against it. I think it's really important now to seize this moment, and it needs to be all of us together. Right now there is a lot of collaboration that's actually wasted, I think, between government and NGOs and clients and service recipients. If we could get our act together, we all want the same thing, and that is for AIDS to not rear its ugliest head again, or come back in that form that we all still remember, or some of us. We could really get quite far, but we do have to act now. We have to kind of put in the commitment. We have to think about different ways of doing it, rather than this. We have our run-of-the-mill publicly funded PHC, where primary healthcare clinic, where there's a lot of efforts and fantastic staff kind of putting in gigantic amounts of work to kind of keep it going. But some of the idea is still that that's happening and that's the government responsibility, and everything that has to do with mobile vans, looking cool, going into places.
That's not our responsibility.
Offering differentiated models of care.
Yeah, because I think with us, what we're always looking for is what are the emerging innovations, whether they're technological, whether they're policy related, but that is the only way when you talk about, if you look at how we grew up and we used to go with the Love Lives and the community workshops. These days, Gen Zs are not there. You're going to host workshops, like most of them are just there for the catering. So we've had to also adapt our model to say, okay, now they're online, now they're more digital, but with the health system, it's still lagging behind and it's still very traditional. And you find a young person going, oh, isn't there another way that I can, can't they just post it to me? Because that is the age that we live in now. So do you see, even though there is a fork in the road, because how I see the fork in the road is that it's either we go back or we go forward, and even in the past, I've always been so anxious about how much support we were receiving in terms of grants, because my head was like, should this stop? What happens? And the worst did happen. So now the question is, are there any possibilities, firstly, for just emerging innovations, whether we're talking policy or technology maybe? And then secondly, how do we move forward and not backwards?
Yeah. So I think it's as an economist, we always think about the supply and the demand side.
Yes.
Basically, people, healthcare providers and healthcare users in this case. I think it actually needs to be a little bit of an effort on both sides.
Yes,
I can
agree.
completely see that people, the mere thought of going to their clinic down the road and joining a very long queue only to be treated as any other person in order to get an HIV test is a fairly chilling idea. But I can assure you, and I've lived in many countries in the world, it's never pleasant to go to a publicly funded healthcare provider. apart from the times where it is. So, for example, all of us, or a lot of us, got our COVID vaccines in in our local clinics, and it was actually really, really nice. Or you go to a community pharmacy and you get counsel a lot more. So, what I'm trying to say is, it might not be the service that you are hoping for, but it's still an important service.
True.
And it's provided at a mass scale, which is why it's cheap, which is why it can be funded by a country, by a government, just like the South African, right? So we won't have the kind of mail drop, here you go, perfectly individualized solution for everyone. It just won't happen. We can get closer to it, and we have community pickup points for drugs, including antiretrovirals, and we have self-tests, and all of that is there. It's just, it might not be perfectly comfortable as an experience. So I think it's a little bit also kind of, all right, you want to keep yourself safe, you want to keep your partner safe, you actually have to get on the road and do something for that.
Yeah. I think that's also our focus, to say what's my individual responsibility. I understand that the government, I understand the nurse, the doctor, everyone, but there's also a level that's mine, and then with mine it is the testing, and also in understanding my situation as well, because we deal, and I think the team will also let you know, that we have sometimes, which is I think it's just the level of maturity of young people, where we'll have a young person going, oh, I don't want to have a child. We're like, okay, that's great. These are the I don't want contraception. And we're like, well, you shouldn't be having sex then, because this conversation is just, so those are also just the personal contradicting views that people will normally have, where you don't have access to medical aid, and therefore your nearest clinic is, and they'll be like, no, there's stigma, people are going to see me. Okay, where's the next clinic then? Because you're not going to the clinic, you know what I mean? So those are the type of conversations that need to be held by people individually, and I think that's where we work, to say, how do we help you to make better health decisions and make more informed health decisions. But I also think that in terms of the role that you are playing and your team is playing in terms of modeling the numbers, speaking to government, that is critical, because without that, I fail to see. I mean, I've traveled to Zimbabwe, Namibia, Lesotho, so I know, in fact, Zimbabwe actually had an experience with their health system, which wasn't bad. I was surprised. It was a public health. I was like, oh, okay, this is good. This is nice. But you see also the difference between other African countries and what's currently happening here in South Africa. And mine is, how do we then strengthen ourselves as a country so that we can replicate what is happening just to our neighbors. I mean, we have young people who travel all the way from Namibia to get sexual and reproductive health care here in South Africa. So how do we become the example, or how do we push it so that we can get more numbers and have more success cases to showcase in other African governments?
I think the one is really to make sure we don't lose the ground that we have won, right? We do have the country's biggest, the world's biggest, not only HIV treatment program, we also have the largest number of people worldwide who've ever tried PrEP. Now, we don't really know how many of those are still on it, or how much actual effective cover, we call it, that translates to. But we have a good 1 million people who've been on PrEP at some stage. So, and that's kind of, I think, if I'm not mistaken, that's 20% of the world. So that we're still doing things at a large scale. And that, as I said, that's not just because government does it and there's all those healthcare workers. It's also because people come and actually demand those services and take them up in large numbers. And I keep thinking that that's not just because someone talked to them, but because people actually have an experience and have a concern about HIV still, which I think is exactly where we need to start. We also, of course, when it comes to migrants, there's nothing more silly than denying healthcare to
that's true
to people from elsewhere, as long as they live in the country, even if they're just traveling through, if they're there for a season or so, they will have contact with everyone else. So yes, that's it's also in the constitution, etc. I think this is really, really important, that migrants have the right and need to be treated just like any other healthcare seeker. I think that's really important. But it's, I think you're right to say there's a number of poorer countries than us and that have better results overall for their HIV response, right? So Eswatini, Malawi, Zimbabwe, all have numbers suggesting that they have done better in getting people on treatment, having them stay there, reducing incidence to levels that that basically suggest they're very, very close to ending AIDS. Now, for them, of course, this change in funding is a lot more catastrophic than for us, because that was 80, 90, and often 100% of their funding coming from other sources. So I do think we also need to ready ourselves for being more attractive in the months and weeks, perhaps years to come, in terms of actually still having HIV care available.
Yeah. And just in closing, as we're trying to wrap it off, what I wanted to know is, what is the one thing that gives you hope about the current health system that we have?
I think it's young people, if I can be blunt. No one wants to slide back in time. No one wants to lose ground again. I do hope that it won't need the drastic experiences that you and I have had to open people to the fact that, you know, sexual health has become more important again, because the chances of actually picking up HIV have increased, because people will fall out of care, will find the clinics closed. You know, all of that is already happening. They, you know, this idea that all of us know our HIV status, and so it's safe to kind of, you know, make assumptions. All that will fall away as well, right? But I do think that people will quickly adopt to that new almost modus operandi, isn't it? And will, you know, that's my hope, will look after their health accordingly. And one of those things is exactly taking condoms more seriously again, opening that situation in a judgment-free way, but also once we have injectable PrEP in particular available, or oral PrEP for that matter, seek out those services, keep yourself safe.
Yeah, and testing, that's very important.
And testing.
Testing is very important. So just in closing, I know you spoke of a time when you were 10 years old and you got your first AIDS training. What do you think 10-year-old Gesine would say to the work that you've done and what you've currently achieved in your career so far?
Probably something like, aren't you done yet?
When are we retiring? Oh, no, you're not anymore. You're going back into the field. Yeah.
Yes.
Oh, that's sweet. That's sweet. So I think, thank you so much for the conversation. It was enlightening. And I think also to the viewers, I hope you see the importance of, firstly, personal urgency and prioritizing your own health, and also seeing how we can work together to strengthen existing health systems. It's been Bongiwe Ndlovu for What the Fuck Wednesdays. See you next week.